So orang tak dapat masuk.
Boleh prepare slides tu? Kita mula dengan mula kita Al-Fatihah. Boleh start dah kot. Okay, make sure 15 minutes, and then we got another like 2-3 minutes untuk discussion and also so I'm not assistant prof, I just doctor.
Okay, sorry doctor. Okay. Assalamualaikum. Okay, may I start? Can you guys see my slide? Yeah.
Yes.
Yeah, thank you. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So today we'll be discussing about the seminar on neurology supervised by Dr. Alwi. Okay, here is the list of the topics which will be discussed for today. Okay, my name is Nurhais Amira binti Matrazi and I'll share about the meningitis and encephalitis. So here is the contents of our discussion for today. First, we need to know what is meningitis and encephalitis. Meningitis is the name suggests it is the inflammation of the meninges, and encephalitis is the inflammation of the brain parenchyma itself. And then this is the etiologies of the meningitis. It can be caused by infectious and also non-infectious causes. I just want to highlight that in infectious there are bacterial, viral, fungal, and parasite. So for viral meningitis is more common compared to the bacterial meningitis. And then usually the viral meningitis is self-resolving, but for the bacterial meningitis, it can cause further complication if not treated promptly. So, and also in addition, due to the vaccine that is developed against the Neisseria meningitidis, Haemophilus influenza, and Streptococcus pneumonia, it reduced the rate of the meningitis caused by this bacteria. So for fungal and parasites, these are rare infections of the cause of the meningitis. So it can usually occur in an immunocompromised patient. So for non-infectious, we have space occupation, autoimmune, and the drugs. For drugs, it is believed that there is two mechanisms that can cause the meningitis. First one is due to the hypersensitivity reaction caused by the drugs and also the direct effect of the drug. Next is the etiologies of the encephalitis. I want to highlight about the herpes simplex virus, which is the most serious treatable etiology of the encephalitis. So for HSV type 1, it can cause infection in after the neonatal period. Type 1 is the orofacial herpes, which can cause focal lesion. For type 2 is the genital herpes. It can cause infection in the newborn child. So it can, but if it is treated promptly, then the patient may resolve by certain weeks, by few weeks. Resolve. And then we'll move on to the pathophysiology of the meningitis and encephalitis. So start with the meningitis. When there is inflammation of the meninges and CSF, it will activate the immune system that will release the cytokines. So when there is increase in the cytokines release, it will cause increase in the permeability of the blood-brain barrier and cause cerebral edema. For the cerebral, cytokines also can cause vasodilation of the vasculature in the cerebral, and it can reduce perfusion pressure, cause ischemia, and increase in the intracranial pressure. And also we go up here, when there is inflammation of the meninges, inflammatory reaction can cause inflammatory infiltrates. So the infiltrates will cause the vasculature to be thickened. So when that it is thickened, the blood flow will be reduced, thus causing the infarction of the cerebral cortex, and there will be fibrin deposits that further block the flow of the CSF by the reabsorption of CSF at the subarachnoid villi. And then for encephalitis, there is two pathophysiology detected, which is the primary and secondary. Primary is the direct effect by the virus itself, and then secondary is the post-infectious, in which it involves the immune-mediated reaction, such as subacute sclerosing panencephalitis, which occurs after measles. And then for the signs and symptoms, actually, when patients come to the hospital, we cannot really differentiate between the features of meningitis and encephalitis. So to reach for the diagnosis, we need to depend on three: the clinical features, physical examination, and also the investigation. Okay, for the symptoms of meningitis, the patient might present with non-specific symptoms, which is fever. For example, in neonates, the fever might be on and off. For irritability, for example, if in the parents might complain that their baby refused to be carried, this is what we call as paradoxic irritability, in which the child refers to be motionless, remain motionless, so they do not prefer to be carried by the parents. And then lethargy, drowsiness, vomiting, poor feeding. And for poor feeding, for example, the mothers might complain that their child refused to be breastfed, so that might indicate poor feeding. And then seizure might also happen. And then check for any signs of symptoms of meningism, the headache, photophobia, or stiff neck. So for a headache, a baby cannot tell you that they are having headache. So ask the patient if their child is present with unusual crying, for example, a high pitch crying. So they might indicate something's happened in the child. For headache, also for photophobia, for example, in a child that has headache, they may complain that if they go to the light, the headache may get worsen. So for the stiff neck, maybe they complain that their neck is sakit, painful neck. And then for the increased check for the increased intracranial pressure, irritability, drowsiness, vomiting, episode of fainting, reduced consciousness, and coma. For septicemia, it is important, especially in the meningococcal septicemia, because it can cause severe septicemia that can lead to death within hours. So ask the parents to check if there's any purpura escalation. The rash in meningococcal septicemia, it starts with erythematous. Erythematous just like small, and then it will suddenly develop to purpurate skin lesion, which when you put pressure onto the rash, it doesn't fade, which is called as non-blanching rash. So this is a very carries a very severe effect to the patient. And then for the signs, check for any sign of meningism, signs that can be detected during the physical examination. Neck stiffness, opistotones may be found in neonates from 0 to 2 months. For Koenig and Brudzinski sign, it may present for children more than 12 months. And then check for the signs of increased intracranial pressure. For the sunset eyes, it is believed that when there is increased intracranial pressure, the cranial nerve stick is the one that is more prominent to be stretched and compressed, thus cause the sunset eyes. And then check for any septicemia signs. Okay, next. Okay, this above one is the Brudzinski's sign. So carefully slowly flex the neck of the child, and when there is meningitis, there will be meningeal irritation. So the child may feel painful, and then the hip and the knee will suddenly flex, sudden flexion of the hip and the knee. And then for the Koenig, extend the child's knee for 90 degree and try to strengthen the leg. So when in meningitis, there will be meningeal irritation that can cause pain during the strengthening. So the child may not be able to strengthen their leg. And then this is the bulging fontanelle. Below here is the sunken eye, and then this is the opistotones. So and then this one is the non-blanching rash, which is suggestive of the meningococcal septicemia. And then for the encephalitis, the symptoms is somewhat the same like meningitis, but I want to focus on the behavioral changes. So the patient, the parents especially may complain that the children is like before is happy-go-lucky, but suddenly they become very very aggressive. So without any macam tak ada sebab untuk marah, tiba-tiba marah macam tu lah. Okay, and then for signs, look for any neurological symptoms. It depends on the side of the brain that is affected. So, and then also, just like I've mentioned before, for the post-infectious encephalitis, so look for any skin rash that is maybe caused by measles or varicella. Next, we move on to the history taking. So patient might come with a complaint of fever, vomiting, headache, or seizure. So ask further about those complaints. For example, fever is it on and off? May be suggestive of it. And then vomiting, it may be projectile or may not. And then for headache, seizure, is it the first episode or is it the recurrence of the seizure? And then for the HOPI, ask about the triad of meningitis. If there's any fevers, neck stiffness, and headache, and also other signs mentioned before. So for the sputum and the cough, usually meningitis it preceded with the upper respiratory tract infection, and then ask if there's any cough developed in the patient. And then for the tick and mosquitoes bite, also need to be asked if those are the vectors that can transmit the virus. And then for the past medical and surgical history, these are just to check if there's any immunodeficient state in the patient. So for example, the congenital immunodeficiency and others. For the cochlear implantation, it is likely suggestive for Streptococcus pneumonia meningitis. And then for penetrating head trauma and also the recent neurological procedure, it may be suggestive of staphylococcal meningitis. For hemoglobinopathy such as sickle cell disease, and also the post-infectious encephalitis, which follows the mumps, measles, or varicella. And then for the drug history, ask if the patient is in a prolonged antibiotic therapy, it may cause immunodeficiency in the patient, or even the drug.
Sorry. Hello. Sorry. Tadi I macam pecah-pecah lah. Sorry. Internet I tak bagus. You mentioned hemoglobinopathy tadi apa? Dia punya organism?
Sickle cell disease.
Yes, I mean. Kenapa you kena tanya pasal hemoglobinopathy tadi?
Because it is one of the cause of the, but I cannot really find
what you mentioned about the I can't really get what you're saying.
The hemoglobin, based on what I've read, it may cause, it's like a risk factor, but I cannot really find how it caused the meningitis. Is it, or is it wrong?
Sambung masa bang. Tak apa.
Sambung.
Continue.
Okay. For immunization
Number.
history, okay. Immunization history asks if it's up to date or not for the, especially for the meningococcus that is for the Neisseria meningitidis, the Haemophilus influenza, MMR, and also pneumococcal. For the developmental history, there might be developmental delay due to the complication of the meningitis, but usually this one is, it presents as a late complication, so you might find it during the follow-up usually. And then for family history, if there's any sick patient, sick family members, might be, for example, chickenpox, which can the family member can transmit the virus to the child, and then history of epilepsy because the patient present with seizure. So ask further about the history of the epilepsy in the family history. And then for social history, as if the patient is sent to the daycare centers, or is there any TB contact. For the investigation, we do the laboratory evaluation, neuroimaging, also the neurophysiologic studies. So for blood, check for the full blood count, may indicate infection. Neutrophilia may suggest of bacterial infection. For leukocytosis may suggest viral infection. Coagulation screen, because a patient may present with septic with shock, so there might be the IVC. And then C-reactive protein to check for the inflammatory markers, the serum electrolytes, especially the sodium, because patient might be complicated with SIADH. And then for the blood glucose, maybe the seizure is caused by the hypoglycemia. And then check for the liver function test if there is any infection towards the liver. And then the CSF studies is the diagnostic test to check for the meningitis and encephalitis. And then the detection of the organism by the culture, rapid antigen test, and also the PCR. For neuroimaging, it may be indicated if there's suspicion of subdural empyema of effusion, and also to check if there's any hemorrhage in the brain. And then for MRI in encephalitis, not only MRI, CT scan also. For encephalitis in HSV encephalitis, there might be lesion on the temporal lobe. So check further on that. And then neurophysiologic studies might show slow brainwave activity on the EEG. And then if TB is suspected, for example, if the patient present with chronic cough or any TB contact, so check for the chest X-ray, and then the Mantoux test or IGRA. And then for the gastric aspirates, for the child that cannot who cannot give the sputum, then we may proceed with gastric aspirates. And then do microscopy and culture. So here is the lumbar puncture to check for the CSF study. However, there are a few contraindications to the lumbar puncture. For example, the coagulopathy, such as severe bleeding, and then cardiorespiratory instability, focal neurological signs such as papillary edema, which suggests increase in intracranial pressure, then local infection, and if it causes undue delay in static antibiotics, such for example, if there's any sign of, if there's any risk for brain herniation, then cannot. And then thrombocytopenia, if there and also the signs of increase in intracranial pressure. So here is the result of the CSF. Just focus on the meningitis. For bacterial meningitis, the appearance is turbid. For viral meningitis, it's clear. And tuberculosis, it can be turbid, clear, or viscous. And then for bacterial also, it can be it is neutrophilia, and then for viral lymphocytosis, but initially it might be neutrophilia at first, then proceed with lymphocytosis, and then tuberculosis, there might be increase in the lymphocytes. For the bacteria, Gram-C may be positive, and then for viral, virus might be detected by the polymerase chain reaction, and for tuberculosis, the acid fast. And then, okay, for encephalitis, it's clear appearance, and the CSF virology can detect the HSV and the PCR. So here is the complications of the meningitis and encephalitis. For example, the meningitis, it can cause early and also late complications. Cerebral infarction that can cause seizure, and then cerebral edema, cerebral abscess, local vasculitis, meningococcemia that can cause DIC and also coagulopathy, shock, and also SIADH. And then for the late complications, usually we do follow up about 4 to 6 weeks, and then to check if there's any complication from the meningitis. For example, the cerebral palsy, blindness, deafness. So during follow-up, check for the hearing test. For mental retardation, behavior problem, epilepsy, hydrocephalus, check for the head circumference, and then check for the developmental delay. And then for encephalitis, usually most of it are usually the patient who have encephalitis, they may resolve about 2 to 3 weeks after the infection, but in severe cases, it can cause death, and there might be substantial neurological sequelae, such as paresis, cognitive impairment, weakness, ataxia, and recurrent seizure. So next is the brief management of the meningitis and encephalitis. So for meningitis, there is supportive and medical management. For supportive management, patient may develop shock, so monitor the vital signs and also resuscitate the patient. For medical management, give the antibiotics, such as according to the age group, this is on pediatric protocols. And then for steroid, it is believed that there is when we administer steroid, it will reduce the incidence of hearing loss caused by the Haemophilus influenza, and also the neurological sequelae and mortality by the pneumococcal and meningococcal. For encephalitis, there is no specific antiviral given, but in encephalitis, we can do supportive and medical management. So for supportive treatment, continue survey for the continue monitor the seizure if there's any aware monitoring, and also correct the increase in intracranial pressure, and also correct the cerebral perfusion pressure. For the medical management, we'll give antiviral, which is the acyclovir, because that can bring long-term effect, severe consequence. Okay, that's all for me.
Okay, good. Any questions?
Yeah, I have a question. Can you go back to the pathophysiology slide?
It's a bit confusing because you mix. I mean,
Okay.
Okay. Can you explain one more time about that meningitis? I don't get the part where it goes bottom right, where like cytokines and then cerebral vasculature, vasodilation, reduced perfusion pressure. Okay, I understand that. Ischemia, but then how does it lead to a increase intracranial pressure?
So I'll search for it, but it may be because of the ischemia, then it causes a compensatory mechanism which increase the blood pressure and cause the increase in the ICP. Also, it can also be caused by the cytokines itself that can cause the increase in ICP.
Thank you.
ya ke?
Ada baca betul.
So what happened if you pernah dengar tak Kelly Monroe doctrine? Have you heard about Kelly Monroe doctrine?
Tak pernah lagi.
You guys clear tak dengar I punya suara?
Clear?
Dengar clear tak my voice?
Sekarang clear.
Clear.
Oh, ada signal tak bagus lah. But anyway, so what is Kelly Monroe doctrine? Monroe Kelly ke Kelly Monroe? I can't remember. I think Kelly Monroe. Anyone? Do you know Kelly Monroe doctrine?
I guess we haven't heard of it.
Okay. So basically, you have to understand that your skull is a closed series principle kan in physics. I think you guys took physics in your Archimedes principle. Is it Archimedes? Pascal kot? No, I think it's Archimedes. Pascal lah. I remember lah. I think Pascal kot. Anyway, so because in a closed system, pressure will be transferred. Uniformly lah throughout the system kan. So what happen is in your brain there's only 3 components. There's tissues, which is your parenchyma, then there is CSF and blood. So there's only 3 things in your brain. So because these 3 already occupy the whole space of your skull, so any increment in one of these will cause reduction in the other. Faham tak?
Faham?
You get faham kan? So when you have cerebral vascular vasodilation, okay, so what happens? The vessel will expand now. This will vasodilate. This is vasodilation. So what happens is cytokines they cause venous punya vasodilation now. You know when you shock kan, you got ataupun when you've got cytokine storm, you've got shock because of increase in capillary leakage and also vasodilatation. Kan? So what happen is your perfusion will reduce. You know the formula for CPP, cerebral perfusion pressure. Yeah, you belajar tak dekat? I think you should learn in first, second year kan? Intracranial pressure. I mean, you punya perfusion will depends on your MAP. MAP minus ICP. That is your perfusion pressure in the brain. So if you got MAP you sama, you've got same MAP, but you've got higher ICP, so you'll get lower CPP. You get lower cerebral perfusion. Faham tak? I kena draw lah, tapi memang I guna phone, so tak boleh lah guna whiteboard. So anyway, tapi so what happened? You got the brain become hypoxic because when the venous all dilated, so the brain will become compromised because there's not enough space. So the veins will actually press on the brain, and it increase the intracranial pressure. So it reduce the blood flow in the artery lah to the brain. So brain become ischemia. Faham? And it's actually the other way around. It's increased ICP causing ischemia. It's not ischemia causing ICP. However, when your brain is ischemic, any part of your organ, kan, when it's ischemic, it will become edema tau. Brain ischemia can cause cerebral edema. Because there's nanti you belajar physiology, there's a lot of different type of cerebral edema. It's called vasogenic. You've got there's a lot of cerebral causes for cerebral edema, but ischemia can cause cerebral edema. So it's like a vicious cycle lah. You've got increased ICP, then it's cause ischemia, then ischemia cause cerebral edema. Cerebral edema will further reduce your cerebral perfusion and further worsen your ischemia. That's why you got the concept of umbra penumbra. Kan, you faham kan? So the way to go forward is actually to increase your MAP or your BP to push. To reduce first, you have to reduce the edema and then to increase your BP so that your MAP will be increased and it will against the resistance in your ICP. Okay, faham tak? So like I say, susah lah nak faham because I'm not drawing. Tapi you can get the concept kan?
Yes.
Okay, this is very physiology lah. Okay, any other questions?
I have a question.
Ah.
About the Koenig sign, it is positive because of severe stiffness in the hamstring. So how does it relates to meningitis?
Short speaker. Connect. I think we should spend some time lah in this
Clinic. So there
because meningitis and encephalitis is very important.
during the flexion of the knee, there is spinal macam mana dia dekat spinal irritation together with the meningeal irritation that can cause the pain. So the patient cannot further strengthen the knee because they feel the pain. Macam tu ke? Tapi the irritation that cause the pain, so the child cannot flex the knee.
Basically, you have to understand the anatomy lah. Okay, the PIA and arachnoid mitre. Okay, your PIA, the arachnoid. I think the arachnoid. Your meninges got 3 layer kan? You've got the dura, and then you've got the lepas dura apa? Arachnoid kan? Lepas arachnoid is?
Yeah.
Your PIA kan? So dura dia stop dekat brain lah. Dia tak go beyond the foramen magnum. Tapi your PI and also your arachnoid, they go beyond your foramen magnum. It will encapsulate. Dia akan the meninges continue your PI and arachnoid is continue until your apa yang bawah sekali apa? Spine apa dia? Bawah sekali you punya spinal cord. What structure at the end of your spinal cord?
Cauda equina.
Apa dia? Cauda equina, ya ke cauda equina?
Filum terminalis.
Filum terminalis kan. So you ada cauda equina and then filum terminalis kan finally. So all these are covered with your PRN arachnoid. So if you've got meningitis, these are all inflamed and painful. It's continuous kan. So if you stretch them, then because when you 90-degree extension, when you extend 90 degree of your hip joint, you will actually stretch your femoral nerve. Your sciatic. You will stretch your sciatic nerve. And sciatic nerve, the supply is come from your L berapa? Sciatic nerve. Anatomy short. Sciatic nerve dia arise from apa? What is the root? Where is the root? Short sciatic nerve.
Is it
S apa? S.
1, 2, 3.
Sciatic nerve short S. Ya ke S1, 2, 3?
Bukan.
More anatomy short. Apa nak you check? Siapa nama presenter?
L4 S3.
L4 sampai
L4
S3.
S3 kan?
Okay, tak apa. Presenter you check. Okay, what is the origin of sciatic nerve? From where it originates, and then so they stretch down to your where is end? Sciatic nerve. Dia supply sampai mana?
Lower limb.
Dia supply sampai what is the function of sciatic nerve? Macam you nak check sciatic nerve punya function? How to assess sciatic nerve punya function? You assess the thumb kan? The big toe, the thumb pula. The big toe, the great toe. Kita tak call big toe lah. Big toe is later. So scientific term is great toe. So sciatic nerve function dia is flexion, plantar flexion of your great toe. So what happen is they stretch all along sampai bawah. So if you flex the hip and then you extend the knee, it will stretch the nerve. So it will stretch the whole spinal cord. That's when you get meningeal irritation. Faham tak? Faham kan? Oh, okay. Okay, any other questions? Can you give me like 5 minutes?
Sciatic nerve is L4 to S2.
Okay, good. So L4 to S2. Okay, cool. Okay. Okay, this one. Okay, so what else? Any other questions? Hello?
No questions.
Okay, so proceed with the next one. Okay.
Assalamualaikum. So can you see my slide?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Neurology binti Zahri. So today I will talk about the probate seizure. So this is the flow of my presentation. I will start with the definition, pathophysiology, signs and symptoms, tracking, complication, and lastly briefly about the management. So for definition, first let's take a look to the definition of the seizure. Where seizure means the clinical event which there is sudden disturbance of neurological function in association with abnormal or excessive neuronal discharge. So probate seizure means seizure in association with fever in a children between 6 months to 3 months to 6 years old, whereas there is no intracranial pathology or metabolic derangement. The probate seizure is considered as the benign and self-limiting condition. However, most of the parents consider it as a threatening event for their child. And this probate seizure can be classified into two. There is the simple and complex probate seizure. About 5% of the children less than 5 years old will experience it, and between 2 to 5% of the neurologically healthy infant and children will experience at least once in their life. For the pathophysiology, the definite pathophysiology of the probate seizure is unknown. However, there is the possible explanation about how it happened. So from the causes also unknown. However, it is believed that it can be due to the physiologic condition such as the infection or the genetic susceptibility that can lead to the elevation of the temperature. So when this the elevation of the temperature, it will impact the ion channel, which it will increase the glutamate, which is the excitatory neurotransmitter, and decrease the GABA, inhibitory neurotransmitter. So this will lead to the increased excitability and synchronization of the neuronal activity that lead to the probate seizure. Next, for the sign and symptom. So for the fever, the temperature will greater than 38 degrees Celsius. And for the febrile seizure, I put the sign and symptom based on the classification, which we have simple and complex febrile seizure. So for the duration of the simple febrile seizure is less than 50 minutes, where most of the time it will stop spontaneously after 2 to 3 minutes, and it rarely beyond than 10 minutes. For the complex, it will be more than 15 minutes. For the nature of the simple is the generalized tonic-clonic, where the children may loss of the consciousness and have jerking movement all of the limb. Where during the tonic there will be stiffening of the muscle, and clonic is the repeated jerky movement. For the complex, the nature is focal, where the patient do not loss of the consciousness, and the jerking and stiffening just happen at some part of the body. For the recurrence, there is no recurrence for the simple within 24 hours period, and for the complex for procedure, it can reoccur within 24 hours period. For the post-ictal gesture, there is none in the simple. However, in the complex, the child may have the residual neurological deficit. For example, third paralysis, there is the weakening of the affected limb after the seizure. And if the seizure is last more than 30 minutes, we can categorize this as the febrile status epilepticus, and it characterized by continuous or intermittent seizure without any neurologic recovery. And this febrile status epilepticus is a medical emergency, and it needs to be treated with the anticonvulsant. Next, we go to the history taking. So before that, I want to emphasize that the diagnosis of the febrile seizure is based on the clinical diagnosis, and it is the diagnosis of the exclusion. So history taking is really important. First of all, we need to know about the age of the patient. As I said before, it happened between 3 months to 6 years old children. And for the HOPI, patient may have the fever, which we need to know about the temperature, where in the procedure, the temperature will be more than 38 degrees Celsius. We need to know about the duration, how long it has been happened, the onset and characteristic of the fever, and also the alleviating factor. For example, the parents may do the tepid sponging or give any medication to the children in order to relieve the fever. For simply to say, we want to know how the parents manage the fever initially. And for the fit or seizure, we need to know when it happened and what happened during the fittings. The children may be falling or biting the tongue or choking during the seizure. And also we need to know about the episode, whether it is the first time or it had happened before. We need to know about the characteristic of the seizure, whether it affect all of the limb or certain part of the body only. Presence of the focal features if it affects certain part of only. Duration of the seizure, how long it has been happened. Duration between the beginning of fever and the occurrence of seizure, because most of the febrile seizure will be happen on the first day of the fever. The next one is the recurrence, whether there is recurrence or not within 24 hours. Duration of the post-ictal phase and also the post-ictal gesture. And lastly, about any previous history of the fitting before. And for the other, through the history, we also can try to look for the causes of the fever. For example, it may be due to the upper respiratory tract infection. So we can look for the symptoms such as the sore throat or cough, or it can be due to the urinary tract infection. So the symptom may be dysuria, hesitancy, and we also need to rule out the etiology of the seizure. For example, meningitis, and also the history of trauma that can lead to the seizure. And for the patient less than 18 months years old, uh, we need to look for the non-specific or vague symptom in them, such as agitation, bulging fontanelle, and also the excessive cry. Next is the developmental history. Is there any history of any developmental delay that can caused by the neurological problem? Also, one of the etiology of the seizure. Next is the immunization history. Based on the some research, it says that there is a small risk to develop foveal seizure after administration of certain vaccine, for example, MMR vaccine. For nutritional history, we want to know about the diet to rule out the metabolic imbalance, also etiology of the seizure. In the medical history, is there any underlying medical, neurological, or sexual abnormality to rule out the etiology of the seizure? And lastly, about the family history, any family history that have foveal seizure in the first degree and second degree family. The next one is the complication. So for the foveal seizure, there is two complications. There is the recurrence and also the subsequent epilepsy. So the risk factor to happen recurrence of the foveal seizure is the child have family history of foveal seizure. Age is less than 18 months years old. They have low degree of fever, less than 40 degrees Celsius during foveal seizure. There is a brief duration, less than 1 hour, between onset of fever and seizure. Next is the risk factor for the subsequent epilepsy when they have a neurodevelopmental abnormality or complex foveal seizure or family history of epilepsy. Next, I will discuss briefly about the management. So as I said before, the foveal seizure is a benign and self-limiting condition. So that's why not all children need a hospital admission for this condition. However, some may have to be admitted to the ward if that is necessary. For example, to exclude intracranial pathology, especially infection. If there is fear or risk to recurrent seizure, to investigate and treat the cause of the fever beside meningitis or encephalitis, and also to allay the parental anxiety, especially when they stay far from home. Next, the investigation that we can do during the admission, for example, is the blood study. We can do the full blood count to look if there is any infection that may suggest the causes of the fever. Random blood glucose, if there is the hypoglycemia, and also the blood urea and serum electrolyte to look if there is electrolyte imbalance. So these two to rule out the etiology of the seizure. And also the urinalysis if there is a urinary tract infection, blood culture to identify the causative mechanism, and lastly the lumbar puncture to rule out the meningitis and encephalitis. So the lumbar puncture, it must be done if the patient have any symptom or sign that suggest the intracranial infection, or patient has persistent lethargy and not fully interactive. However, it should be considered if the patient age less than 12 years old, especially if they not receive the Haemophilus influenza and pneumococcal immunization yet. And also if the patient is prior to the antibiotic therapy. Next is the electroencephalogram. Actually, it's not indicated even for those with multiple recurrence or complex foveal seizure. Next, we should consult the patient on the benign nature of the condition so that the parents will not really worry about it. So next we can advise the parent on how to control the fever by, for example, avoid the excessive clothing to reduce the temperature, or use the antipyretic such as syrup or rectal paracetamol for the patient's comfort. However, the parent should know that controlling the fever does not mean it will reduce the recurrence of seizure. Next, we can advise and teach the parents on how to do the first aid measure during the seizure. This is especially in the child that have high risk for the recurrent febrile seizure, and also with the child with the febrile status epilepticus. We can supply the parents with the rectal diazepam, and we should advise on how to administer it if the seizure is more than 5 minutes. A bit for the prevention of the recurrent foveal seizure. Actually, the anti-epileptic drug is not recommended for prevention, as the risk and potential side effect of the medication outweigh the benefits. There is no medication that show to prevent the future onset of the epilepsy, and foveal seizure have excellent outcome with there is no neurological deficit or any effect on the intelligence. Lastly, if the child is still convulsing at the presentation at the emergency department, the indication of the anti-epileptic drug can be considered if the seizure is last more than 5 minutes, the children have febrile status epilepticus, or they have recurrent seizure. So that's all for me. This is the summary for my presentation. Thank you.
Okay, any questions? Any question, guys? Dengar tak cakap?
No questions.
Dengar.
Usually, if there's no
Okay lah,
questions, we just stay quiet.
susah lah bila you stay quiet, I thought you guys tidur, so it's okay lah. Tak apalah, continue with next
No,
one.
no, no.
Tapi we need we only got another 3 ke another 2. Ada 3 kan?
Another 3.
Another 3.
So it's okay. Just proceed. Proceed with the next one. Tapi keep it short. So I think we can focus on nation rather than the rest lah. Just focus on that long history and examination. And also any cell. I think management we can keep good. Management just you can cover a bit. Pathophysiology I also boleh skip lah. Just tak cukup masa lah. Okay. Okay, next.
Okay. So can you guys see the slide and hear my voice?
Yes.
Okay. Okay. So actually, I don't quite listen to what doctor said. What should we skip?
Okay, just focus on the history and clinical examination.
Oh, okay.
The rest you can just add any like salient point from your study from your presentation.
Okay, thank you. Okay, so Assalamualaikum warahmatullahi wabarakatuh and very good evening. So inshallah I will cover on the topic childhood epilepsy. So this topic is quite lengthy, but I will try to make it as brief as possible. Okay. Okay, so we start with the definition first. So basically, from the illustrated textbook of pediatrics, epilepsy is the brain disorder that predisposes the patients to have unprovoked seizure. So the seizure means the sudden change of the neurological function that is caused by the abnormal or excessive neuronal discharge. So someone is said to have the epilepsy when there is at least 2 unprovoked seizure that occurs more than 24 hours apart, or 1 unprovoked seizure with a probability of further similar reoccurrence after 2 unprovoked seizure. And it is also as the diagnosis of the epilepsy syndrome, which I will tell later. Okay, so briefly for the pathophysiology, basically the seizure occurs when there is imbalance between the excitatory and the inhibitory mechanism. So there will be with the too excessive of the excitatory mechanism and too low in the inhibitory mechanism. Okay, so this is the current classification for the seizure, and this is the latest and the one that I familiar the most. So it is made by the International League Against Epilepsy 2017. So as you can see here, that is it is categorized 4 types. divide it into 4 types, which is the focal onset, generalized onset, unknown onset, and the unclassified. Okay, so we move on to the focal onset first. So the focal onset is basically the seizure that occurs in at the particular part of the brain. So it is divided into whether aware or impaired awareness focal seizure based on dependence on the patient's status during the attacks. So it is further divided into whether motor and the non-motor focal seizure. So the motor, as we know, it involves the movement. So there is a list of the classification. I will just go briefly. So for the automatism, basically it means the automatic activity, such as the patient may have the licking limbs, the rubbing hands, walking and running. So for the ethnic, there will be loss of the muscle tone. The tonic means the muscle tone. So for the clonic, it means the movement that involve the sustained rhythmic jerking, and usually it involves the distal limb. So if it involves the proximal limb, we call it as the epileptic spasm. So for the hyperkinetic is the movement of the proximal limb also, but in the large amplitude, irregular large amplitude, such as the pelvic thrusting or jumping. But for the myoclonic, it's only the single brief muscle contraction or jerking that lasts only milliseconds. So for the tonic, is the increase in the muscle tone of the stiffness. Okay, so for the non-motor, which is the non-motor under the focal onset, it involves the abnormal cognitive function like reading or speaking, or behavior or sensory function like the visual, auditory, or pain or emotional. Okay, so for the generalized, unlike the focal, the generalized is involved the seizure that occurs and started in the both side of the brain. So in the generalized, there is no classification of the whether aware or impaired awareness, because all of them is presumed to have the impaired awareness. So basically for the motor is quite similar to the focal onset, but for the first one is the tonic clinal seizure is the most common among the generalized seizure. So it consists of the tonic and the clonic, which is I already explained before. But the difference is that in the generalized onset, it involves the bilateral side. So the rest, like the clonic and the tonic, is just the same. So this ethnic myoclonic and epileptic spasm is the same like the focal one. Okay, but for the non-motor seizure under the generalized is called the absence seizure. It is quite different, like from the focal onset, and because it does not involve the cognitive functions or behavior or emotion. Instead, it is the patient is seen disconnected from the others and will have the stare blindly into the space. So it is categorized under typical, which is the abrupt onset or the offset of the outer awareness and associated with the staring. For the atypical, the person will have the staring also, but it may be respond a little and associated with the clonic or tonic. So for the myoclonic, there will be the rhythmic jerking of the shoulder and arms with either complete or the partial loss of the awareness. So for the eyelid myoclonia, is the brief rhythmic myoclonic jerks of the eyelids that have a simultaneous outward deviation of the eyeball and the extension of the head. Okay, so for the etiology, there will be lots of the causes that can contribute to the epilepsy. So briefly, for it has a genetic, like the non-gene defect in the Dravet syndrome, which is the mutation in the SCN1A gene, or the structural, whether it can be due to congenital, like in the cortical dysplasia, tuberous sclerosis, or in the acquired, like when the patient have stroke, trauma, infection. So for the metabolic, we see in the glucose transporter deficiency, mitochondrial cytopathies, or immune or infectious causes that have the chronic infectious condition, like in the TB, HIV, or malaria, or it can be simply as due to unknown causes. Okay, so for this theta epilepticus is it already been explained in the febrile seizure just now. It is the pediatric emergency with the continuous seizure for more than 30 minutes or repetitive seizure without recovery or consciousness more than 30 minutes. So it can be due to the new onset epilepsy, the drug intoxication, the drug withdrawal, especially in the anticonvulsant, hypoglycemia, electrolyte imbalance, and so on. Okay, so that also the epilepsy syndrome, which means the complex of the sign and symptom that define a unique epilepsy condition. So briefly, for the infantile spasm is the brief contraction of the neck, trunk, and arm that is followed by the sustained muscle contraction. So it is called West syndrome when there is a triad infantile spasm, developmental regression, and the hyperarrhythmia in the EEG pattern. So it occurs in the patient in the 3 to 8 months. For the next one is the Lennox-Gastaut syndrome. So it is the severe epilepsy syndrome. So it is characterized by the frequent multiple seizure type like atonic, focal, generalized, tonic, clonic, or absence. And this Lennox-Gastaut syndrome is difficult to control and it can cause the significant intellectual disability. For the childhood absence epilepsy, the name suggests it characterized by the absence seizure that lasts less than 30 seconds. So the patient can have the staring and loss of consciousness. So this childhood absence epilepsy, if it does not remit, 44% of them will be develop the juvenile myoclonic epilepsy, JME. So this JME is common among the adolescents. So it is like the name suggests, it is characterized by the myoclonic jerking, generalized tonic and clonic seizure, and the absence seizure. So basically, this epilepsy syndrome is just a collection of the epilepsy type just now. Okay, so here we have a benign epilepsy with centrotemporal spine, also known as the benign Rolandic epilepsy. So it can occur during the sleep and on awakening. So, the patient can have the focal motor seizure that involve the face and arms. So for the benign neonatal convulsion, it is the autosomal dominant genetic disorder that that cause the patient to have abnormal neuronal potassium channel. And for the acquired epileptic aphasia is also known as the Landau-Kleffner syndrome. So it is characterized by the abrupt loss of the previously acquired language. So in the EEG, there will be abnormality in the language area. Okay, so how to diagnose the epilepsy? Like I said before, in the definition, it is diagnosed when there is at least 2 unprovoked seizures that occur in the more than 24 hours apart, or 1 unprovoked seizure, and with a probability of further similar reoccurrence after 2 unprovoked seizure. So in epilepsy, the history taking is the most important part in the diagnosis. So basically, we need to ask the characteristic of the seizure event, whether from the eyewitness or the patient himself. So we can ask whether the event is associated with a fever or not, whether it is this is the first time or the patient have the previous attack, and how long did it last, whether the patient is the patient is aware or loss of consciousness, the frequency, the time, and the date of the last seizure, any triggering event that contribute to the seizure, any family history, and any significant developmental history. So, and we can, from the history, we can identify the risk factor and the causes so that we can plan for the management later. And in this modern era, the video recording of the seizure event is very helpful to establish the diagnosis. And for the examination, basically, the important is the neurological examination. So in the neurological examination, we can check for any muscle spasm, any eye deviation, any automatic muscle movement. So this is important so that we can categorize the epilepsy types. So for the investigation, it is to establish the diagnosis, and we can exclude the other differential diagnosis. So we can do the neuroimaging like CT scan or MRI, preferably MRI, or we can do the electroencephalogram EEG. But then this, when the EEG result is normal, we cannot exclude the epilepsy when there is a convincing clinical history. Okay, so for the investigations, since there is many etiologies that can contribute to the types, so there is lots of investigation that we can do to the patient. So for the blood test, we can do the full blood count, BUS, renal profile, random blood glucose, serum calcium, liver function test. So from them, we can expect to have increase in the sodium or calcium level, and we can use them to exclude any metabolic causes. So next is the EEG. EEG is important to support the clinical diagnosis or to classify whether what is the syndrome or what is the seizure types, and it can help in localizing the focus onset seizure. Means that we can look for any distinctive wave, and we can determine where which lobe is affected, or we can have an idea on the underlying structural abnormalities. So neuroimaging like CT scan and MRI we can do to detect any structural abnormalities. So for the others, we can do the ECG if we suspect cardiac dysrhythmia or long QT syndrome. So this long QT syndrome is the syndrome that can mimic the seizure presentation, but it is not the true seizure. Or we can do any autoimmune antibody screening to exclude the autoimmune causes like anti-NMDA, like I have mentioned just now. Okay, so this is the example of the EEG finding. So in this graph, we can see the elevation or abnormal in the certain lobe of the brain, or we can see in the MRI the lesion that affects the brain. Okay, so for the management, okay, briefly for the management, the anti-epileptic drug, I will put the example later. So this anti-epileptic drug is recommended if there is more than 2 episodes. So if so we need to give the drug. We start with the monotherapy, and we can increase the dose gradually until epilepsy is controlled, or the maximum dose is reached, or is there any side effect. So the concept here is to start slow with the drugs, and we need to avoid sudden withdrawal. So if this anti-epileptic drug is not responding, the patient is not responding to the drug, so we can give the ketogenic diet. So this ketogenic diet is proven to succeed in the management, because this ketogenic diet can reduce the glutamate in the brain and enhance the GABA synthesis. And also this ketogenic diet can reduce the brain inflammation. So the others, we can give the advice on the lifestyle. So we can ask the patient to avoid any sleep deprivation, use the shower with the unlocked door, and to avoid any activities the patient is doing alone, and to inform the teachers and the school about the condition. Okay, so this is the list of the anti-epileptic drug. So I think that's all from me. Is there any part that you want me to clarify or anything else?
Any
Um,
questions?
yeah. Can you explain what is the unprovoked seizure? What is the difference between the provoked seizure again? I'm sorry.
Okay, so unprovoked seizure. Actually, I find this unprovoked seizure. Not sure where did I found it. Mm, I'm sorry, I could not find it right now, but can I give the answer later?
Okay.
So unprovoked seizure is just seizure that not provoked by anything lah, any stress. Any form of stress did not provoke the seizure. Contoh fever ke, illness ke, electrolyte imbalance ke, physical stress, emotional stress. So these are called unprovoked seizure. Seizure caused by no reason. Okay, any other questions?
I guess no question.
Okay, boleh proceed, boleh proceed. Make sure by 4 kita end all everything. So make sure in 15 minutes you should complete your presentation.
Assalamualaikum. Can you hear me and see the screen?
Yes.
Okay.
Yes.
So next we're going to be talking about muscular dystrophy. For my presentation, I'll just briefly go through the types of muscular dystrophy and then focus on the most common type, which is Duchenne. Okay. Muscular dystrophy is a group of inherited disorders with progressive muscle degeneration. So it's genetic disorder. These are the types of muscular dystrophy according to the group of muscles that they affect. So the most common one is Duchenne, which affects the proximal part of the lower limb and also proximal part of the upper limb and respiratory muscles, the throat, and so on. So these disorders have specific patterns of inheritance, such as Duchenne and Becker, which are X-linked, and some disorders also have multiple patterns of inheritance, like limb-girdle or Emery-Dreifuss muscular dystrophy. So the mutations that occur in these diseases, they affect the proteins in the muscles. So this is just a picture. I just want to focus on this particular protein, which is dystrophin. So dystrophin is affected in Duchenne and Becker muscular dystrophy. And these two diseases are known as dystrophinopathies. They affect the same gene, but cause different mutations. So the features are similar, but they have different onsets and the severity is also different. The mutation in Duchenne causes loss of dystrophin, and in Becker, it causes misshapen dystrophin, but it is still semi-functional. So you would have milder features of the disease and later onset. Okay. Now we proceed to Duchenne. Duchenne is an X-linked recessive disorder. However, in a third of cases, it can also be due to de novo or spontaneous mutations. What happens in Duchenne is that there's a deletion at the short arm of the X chromosome. So that locus is where the gene that produces dystrophin is located. This is a picture of a normal muscle cell. So in the muscle, you have this dystrophin protein, which functions to stabilize the plasma membrane of the muscle. So when you don't have dystrophin in Duchenne, such as in Duchenne, the membrane becomes unstable, and whenever the muscle contracts, the membrane can break. So when the membrane breaks, you'll have influx of calcium ions, and this calcium will ultimately lead to breakdown of muscle by binding to proteases inside the muscle cell. Other than that, you also have efflux of creatine kinase, which is important as a diagnostic test. So you can measure serum creatine kinase. I'll explain later. So after breakdown of muscle, eventually the lost muscle will be replaced by fat and connective tissue. So you will have specific manifestation related to this, which will also be shown later. For the clinical manifestations, the usual onset of Duchenne is from 2 to 3 years old, and Duchenne selectively affects the proximal before distal and the lower before the upper limb. So the early manifestations, you'll see symptoms of weakness of the lower limbs first. And only after that, during the teenage years, you'll have weakness in the upper limbs, and then weakness in the respiratory muscles and in the throat and so on. Okay. So one of the some of the manifestations that you can expect are delayed walking, difficulty running, going upstairs, frequent falling, clumsiness, and the mother or parents might also tell you that the child has inability to keep up with their peers. So these are all manifestations of lower limb weakness. These are some of the signs that you can look for. The first one is a waddling gait. So waddling gait is like jalan-jalan itik. This is due to the instability of the pelvis. So the child has to walk with the macam tu. Next is lumbar lordosis, which is the exaggerated curvature at the lumbar spine, also due to pelvic instability. The pelvis tilts anteriorly, and so the spine has the curve to maintain the posture of the child. Next is Gower's sign. This is a classic sign of Duchenne muscular dystrophy. So Gower's sign is when the patient is sitting or in prone position, when he has to get up, he has to use his hands to support his body to get up, like in this video. Next, other sign of Duchenne would be toe walking. So patient would be walking on his toes or tiptoeing. This is due to contracture of the Achilles tendon. The Achilles tendon is shortened, so kaki dia, the foot is plantar flexed. Another sign of Duchenne is calf muscle enlargement or pseudohypertrophy, because the muscle itself isn't actually enlarged, but the muscle tissue is replaced by fat and fibrotic tissue. So you would have this enlargement of the calves. Other manifestations of Duchenne include learning difficulties and dilated cardiomyopathy, because in the heart, you also have dystrophin in the heart. So when you have no dystrophin, you would have weakened heart muscles. So that would cause cardiomyopathy. Complications of Duchenne is that the patient will have loss of ambulation, not able to walk by 10 to 14 years old. And this will also progress scoliosis in the patient. Most patients die by their late teens to 20s, usually due to respiratory failure or heart failure or respiratory infection. So for diagnosis of Duchenne, you should suspect Duchenne in these three situations. The first one is any evidence of delayed motor milestones with positive family history. So, for example, if the patient is not walking by 18 months and also has positive family history, the mother is a carrier for Duchenne. So you should suspect DMD and proceed with a test to confirm. The next one is no family history, but either one of the following signs: not walking by 18 months, Gower's sign, toe walking, or cuff pseudohypertrophy. And the last one is unexplained increases in transaminases, because these are enzymes present in the muscles. So to confirm Duchenne, The first test you need to do is get a serum creatine kinase level. And if the level is markedly elevated, then you proceed with the test to confirm the diagnosis, which is genetic testing. If somehow the genetic testing gives you negative results, then you can do a muscle biopsy, and the muscle sample is sent for immunohistochemical staining to stain the dystrophin. This on the left is a normal staining for dystrophin. The dystrophin will stain brown, but in Duchenne, you see nothing. There's absence of dystrophin, so there's no staining at all, no brown staining. So this is just brief management for Duchenne. There is no cure for Duchenne, but there are a lot of symptomatic and supportive methods. The first one is administration of glucocorticoids, which is to preserve mobility and to prevent scoliosis. The second one is physical therapy, also to encourage mobility and to prevent or delay contractures of tendons or muscles. Next is to provide adequate nutrition to the patient. The important one being calcium to prevent osteoporosis. The heart and the respiratory function of the patient should also be monitored, and ACE inhibitors or ARBs can be given for cardiac symptoms. If the patient has any signs of respiratory impairment, then the patient should be put on ventilation, and respiratory infections should also be promptly treated to prevent complications. That's all for me. Thank you. These are my references. Questions?
Great. Any questions?
Yes. Is there any pain associated with muscular dystrophy?
Oh yes, there is. Oh, I forgot to put that in. Yes, there is muscle pain occasionally.
Muscle pain, is it? What sort of pain? What causes pain in muscular dystrophy?
I'm not sure. I'll try to find the answer.
Okay, and get back to us. Okay, make
Yes.
sure all the question answered. You guys will answer all the question and share with us. Okay. How about gene therapy? Is there any role for gene therapy for DMD?
Gene therapy. There is studies going on that apply gene therapy, which can try to restore the deleted part of the gene. But I'm not sure if that is the gene therapy is being administered now in routinely. Is it?
Okay, Taufik, so check on that and then share with us. Okay lah. Anything else? So how do you assess when to give steroid? Do you give steroid at early on, at diagnosis, at 10 years old, 12 years old? When do you give steroid?
You give steroids at time of diagnosis because it can delay the loss of ambulation, delays the decline in muscle strength, and increases the time the patient can maintain independent ability to walk.
So if the patient diagnosed at 18 months, I mean got delayed walking and then diagnosed, do you give steroid? Because you mentioned you give steroid to prevent loss of walking, kan?
Yeah.
So if patient never walk, do you give steroid?
I'm not sure.
Okay, tak apa. So, okay, any other questions? This one management lah. Maybe later we learn. Okay. Okay, kalau tak ada, then we can move on lah. Okay, next.
Can you guys see my slides?
Yes.
Okay, sorry. Okay. Bismillahirrahmanirrahim. Today I will present regarding the cerebral palsy. So this is my outline, and for the overview, so the cerebral palsy means a group of permanent disorder of movement and posture causing activity limitation that are attributed to non-progressive disturbance in the developing fetal or infant brain, and it is often accompanied by disturbance of cognition, communication, perception, sensation, behavior, and seizure disorder, and secondary musculoskeletal problems. And we should notice that this is the permanent disease, but it is not progressive, and it is most common motor disability in childhood. Okay. So for the etiology, it is often multifactorial. Um, However, you can see that the antenatal, it is account 80% of the causes, and I think you can read the causes. For the intrapartum, about 10%, and for the postpartum, it is about 10%. So, yeah. So for the pathogenesis, I could not find the specific pathogenesis of the cerebral palsy, but I can find one pathogenesis of one of the causes, which is the periventricular leukomalacia. I already made I already simplified this, and I think you can read this. If you do not understand, you can ask me later. So for the classification, I put 3, which is the motor, topographical distribution, and also the gross motor function classification system. So for the motor types, we have 4. First one is the spastic. Spastic account about 70 to 80% of the CP, and it is occur due to the damage of the pyramidal or corticospinal pathway. So the person may present with the muscle stiff and tight, or we know as the hypotonic. And also next is the dyskinetic. It is account 6%. It is occur due to the damage to the basal ganglia, and it is characterized by the involuntary movement of the muscles. And lastly is the ataxia. It is account 6%. It is arised from the cerebellum damage, and it is characterized by the shaky movement, and it affects the balance and sense of the positioning in space. And we have another one is the mixed type, which is the combination damage. So this another classification. So I think I will explain this later. And also this one. So for this one is the classification based on the uh, motor functions. So for the level 1, the person can walk without limitation. They do not need any railing to climb the stairs. They can run, they can jump. For the level 2, they need a railing in order to climb the stairs, and they have the minimum ability to run and jump. For the level 3, they need the handheld device in order to move. And for the level 4, they use the self-mobility um, device with the powered mobility. Like you can see, they use the con- control wheelchair, and the last one they use the manual wheelchair, which they need the persons to move them. So this one is the important. So the clinical manifestation. So we have the early features of the cerebral palsy, where we can detect in the newborn. So first is the excessive docility or irritability. Docility means easy to manage. So the baby can be excessive, easy to manage, or excessive irritable. And next is the feeding difficulties with the oromotor incoordination, slow feeding, gagging, retching means the act of vomiting, and also the vomiting itself. And it can present with the abnormal reflex, abnormal muscle tone, and also the asymmetric movement pattern. Asymmetric hand function before the 1 years old. So this asymmetric hand function is referred to the hand preference, where we can see in the hemiplegia patient. So for this patient, they have the paralysis occur half of the upper and lower limb. So they tend to use the non-paralysis hand to move. So it is detected in earlier. So for this figure, it is compared between the normal motor development and also the abnormal motor development. So we can see during 3 months, we expect the children boleh menyarap, but suddenly the children even cannot lift up their head. For the 6 months, we expect the children to sit with the support, but yeah, the children unable to lift the head, flow fitra, and so on. Um, and for the and I think you can read about this. So we go to the another subtypes of the cerebral palsy, which is the spastic cerebral palsy, which is account 70 to 80% of the causes. So under this, we have three type of paralysis, which is the hemiplegia, diplegia, and also the quadriplegia. So what is the hemiplegia? It is the unilateral upper and lower limb affected. So the arm usually more affected. So the general the patient will initially flaccid and hypotonic, but then the patient become hypertonic, and the patient also associate with a low intellectual level, and 1/3 of the patient will develop seizures. So for the hand, the patient may have the fisting hands, and the arm and the wrist will be flexed. And also, I mentioned just now the asymmetric reaching, where they tend to use, they have one hand preference, and also the pronated forearm. I will show the picture later. So for the leg, the patient will have the delayed walking and also tiptoe walk, the to heel guide. So for the signs, we can see it is ankle clonus, puppy skin size, increased deep tendon reflex, hand weakness, and foot dorsiflex. So this is the figure of the hemiplegic. You can see how the hand and how the leg of the patients. So for the sign just now, I mentioned about the ankle clonus test. So the ankle clonus test is when the person had the repetitive movement of the ankle after the physician applied uh, force one forcible dorsiflexion. So the ankle keep eh, repeated until if it's from what I read until it is about more than 5 times, it is indicated as the damage of the upper motor uh, neuron lesions. So the next one is the Babinski sign. So for the Babinski signs, it is when the lateral plantar of the foot is stimulated, the tooth is expand, and also the fanning of the other tooth. So this is also indicator of the um, upper motor neuron lesion, and this is the tiptoe walking. So for the next one is the diplegia. So diplegia is where the all limbs are affected, but the upper limb is preserved, uh, but legs are more severe affected. And it is associated with the preterm periventricular brain damage. The prognosis is normal. Patient have the normal intellectual, which is good, and the seizure is minimal. So the generally the child we had the dragging leg while crawling. It is like a commando crawl. And for the hand, it is a clumsiness in grasping. And for the leg, they had the abnormal and delayed walking. They also have the club foot. Club foot mean the foot is rotate to the inwards, and if it's severe, it is disuse, atrophy, and impact growth of lower limb. So for the sign, it is same like before this. The patient will present with the ankle clonus, bilateral Babinski sign, but with the addition of wrist reflex. So the wrist reflex, increased wrist reflex means the upper motor neuron lesions, and it is being tested by using the tender hammer. And we have the scissoring gait. So for the scissoring gait, it is like this picture. It is the rigidity and excessive adduction of the leg like this. And for the next is the quadriplegia. So this quadriplegia is where all four limbs are severely affected. And the general the children have the extensive posturing. They have the poor head control. They also have the swallowing difficulties due to the supranuclear bulbar palsy, and they have the low central tone. And it can be associated with the seizure, microcephaly, moderate or severe intellectual impairment, and they also have the flexion or contraction of knee or elbow. The signs, it is like before this, it's increase in tone and specificity, but it is reduced in spontaneous movement, wrist reflex, and also the Babinski sign. So this is the figure of the quadriplegic child and also the diplegic child. So next, this is less common, but I will mention also. So this kinesia is a involuntary or uncontrolled movement. It is also known as the athertoid cerebral palsy, and it may be described as the chorea, irregular, sudden, and brief non-repetitive movement. Athertosis, which is the slow rhythm movement that occurring more distally, like the fanning of the finger. Arrhythmia, what I read is the like the twisting like this, and also the dystonia. It is the simultaneous contraction of agonist and antagonist muscles of the trunks and proximal, and often giving a twisted appearance. So for this, they often present with the floppiness. So you can see that the floppiness it is occur due to the low central tone of the body, and the uh, baby is look like a U-shaped position, and they may have the feeding difficulty, tongue thrust, drooling, and speech may also affected. So last one is the ataxia or hypotonic cerebral palsy. It is most are genetically determined. So for the early sign, the trunk and limb are hypotonia, and it is poor balance and delay motor development. But for the later sign, the uh, child may develop in coordinate movement, intention tremor, and ataxic gait. So okay, we move to the history taking. So the patient may present with the complaint of developmental delay or complication of cerebral palsy like swallowing problem, aspiration, pneumonia, seizure. And for the HOPI, we should ask detail about the presenting complaint. And we should ask also about the birth history, about the prenatal, if the mother have any prenatal exposure to the illicit drugs, toxins or infections, or the mother have the maternal diabetes, acute maternal illness, trauma, radiation exposure, prenatal care of any. Ask also about the prenatal care or fetal movement, and also ask about the history of early frequent spontaneous miscarriage. For the delivery, we should ask about the child's gestational age at birth, presentation of the child, delivery type, birth weight, and also the AFCA score. AFCA score is the score that being done after the newborn is birth. And postnatal, we ask about the fetal complication, about intubation time, presence of intracranial hemorrhage, feeding difficulties, and so on. So another we ask is we assess and ask about the developmental history. In this we assess the cross motor, fine motor, language, and the social skill. So the patient may present with the any of this, like the history of gross motor developmental delay in the first years of the life, early hypotonia for the 6 months till 1 year, then followed by the spasticity, hypotonia, abnormal muscle tone, asymmetry or failure to crawl, uh, and this is definite hand preference before 1 year, like I mentioned, the hemiplegia, and also about the current social skill, academic performance, and so on. So if the patient have the unexplained regression, it is likely due to the hereditary neurodegenerative disorder rather than cerebral palsy. So for the medical and surgical history, we ask if the patient, if the children have any illness in infancy like meningitis, encephalitis, severe jaundice, severe sepsis, or any hypoxic ischemic or non-accidental injury or neurosurgery. So for the family history, we ask about the family history of neurologic disease or cerebral palsy. For the social history, we ask about how the baby can disrupt the family routine, their financial uh, consideration, how to support this baby, the social support, and also about if the patient attend any special school. And we also ask about the systemic, we also review the systemic to evaluate for the multiple complications that can occur with cerebral palsy. So for the physical examination, we look at the general. So we look at the posture. Is there any increase in the uh, we, we look at the posture, for example, increase in the extensor tone, feasting, hemi, quadri, or diplegic. The movement involuntary, usually it is caused by the dystonia or chorial attitude, or the voluntary, hemi or diplegic gait or immature gait pattern. We also look for the behavior, sign of complication, and if the patient use any peripheral aids like the wheelchair or the walking aids. So we need also to assess the growth assessment to evaluate any growth disturbance. And for the developmental assessment, we should assess like uh, just now, we assess for the motor development and posture, and also the neurological examination to evaluate any of motor tone and coordination, and to evaluate any limitation in functional abilities. So the CP is the diagnosis of the exclusion. So uh, we need to exclude others differential diagnosis like the inherited metabolic disorder, intellectual disability, hereditary neurodegenerative disease, Rett syndrome, and many more actually, but I put some um in order to diagnose the CP. So investigation and diagnosis. So it is made by clinically. It is based on the history and examination just now, and it is not easy to detect early. And there's no specific test to confirm or exclude the diagnosis of CP, but we need to evaluate to identify the underlying cause of CP. So from the history, we need to confirm the history to exclude any progressive or degenerative central nervous system disorder. We need to classify the CP type, and then we need to screen the any cerebral palsy complication, and then we move to the MRI. So this MRI, we can, from what I read, we can establish the etiologies, and for this EEG, it is only for the uh, children that develop seizure. We want to check them, and we also can um, proceed to another test if we like the metabolic and genetic test if you want to um, establish the diagnosis is caused by the metabolic disease or it is caused by the genetic or the thrombophilia. It is not preferred unless the patient is having or exposed to the perinatal stroke. And also if we should do the infectious evaluation if you suspect the causes is caused by the uh, infection like the torches just now. And also we also need to screen the hearing and vision. So for the complication, I think I put many right here, but I will, yeah, I think you can read, but I will mention it a bit. Um, so mainly the patient may have for the orthopedic is the scoliosis. For the nutritional and GI complication, the patient may have the failure to thrive due to the feeding difficulties just now. And for the respiratory complication, they may have increased risk of aspiration due to the oromotor dysfunction. And for the neurological complication, like just now, seizure, epilepsy, and also from the cognitive or psychological behavioral complication, like the mental retardation, learning disabilities, and so on. So for the management and prognosis, there is no curative treatment. The aim is to improve quality of life, and it is multidisciplinary team approach NDT. So for the medical, we need to assess the patient, how the patient condition and so on. And if the patient need the muscle relaxer, we can give the diazepam, baclofen, dantrolene sodium. And if the patient develops seizure, we can give anticonvulsant. And this is from another one is the botulinum toxin A. It is used for the antispasticity, but the effect is only for temporary. So next is the psychiatry. We can refer to the psychiatry because the patient may have the psychological and social problem. So for the education, need to help with the children for the school and the intellectual progress. Rehabilitation, the patient may have the physiotherapy and also the speech therapy, and the patient also may need to use the external aid like the wheelchair and foot orthosis. So the prognosis, most children that survive to adulthood, and it is based on the pattern evolving signs and the child's development progress. So I think that's all from me. This is the summary and this is my reference. Okay.
Okay, Assalamualaikum. Very good. Especially the assessment part. I think management. Sorry, the management. And that's very good because as you mentioned at the end, CP they usually survive into adulthood. So they've got a lot of complication, So they have to go through their schooling age because most of them except for maybe quadriplegia, they may have it may involve their intellectual, but CP should not affect the brain lah. It will some sort affect the cognition. Tapi macam hemiplegia, diplegia, some of the diplegia, they have normal IQ, so they can go to school. They can perform to school lah, like everybody else. So schooling is a major issue in these children. So these are the things you have to discuss and manage. The complication, but otherwise, management is more to conservative lah, and prevention of complication. So what is the most important complication that will actually affect their the prognosis of the children, the life expectancy, for example?
Wait.
What is the most important complication yang you kena prevent, you kena manage?
Is it aspiration?
Okay, aspiration good. What else? Aspiration because
Epilep-
due to oral motor punya ni kan.
Yes.
Epilepsy not so much.
Failure to
Actually,
nutritional.
usually nutritional not so much. In fact, sometimes we don't want them to be too fat.
Oh.
Okay, because for example like normal children kan, we determine the calorie based on weight lah, based on height, but usually based on weight. Tapi in CP children, there are ways untuk determine the calorie. There are a few ways. For example, using the length, the tibia length. So you measure the tibial length, and then that's you formulate the calorie requirement, because they don't need as much calorie as those who actively moving children, especially those with quadriplegia lah. So calorie is not so much, and sometimes we don't want them to be too fat because it'll burden the carer kan. Lagi what else? What other epilepsy? Not so much in CP kan actually. Usually CP yang banyak epilepsi ni is CP yang hemiplegic. Hemiplegic they tend to get epilepsy lah. But quadriplegic usually they don't get CP. They rarely have problem with seizure. They do have problem with movement problem, but not actually seizure lah. But they can get seizure. Tapi seizure usually doesn't affect the mortality. The other one is kyphosis. I mean scoliosis. Scoliosis is very important because it will restrict the lung. Scoliosis will restrict your lung. So a child with scoliosis, they've got higher risk of death when they got infection lah. Okay. The rest is also need to be tackled lah, about sleeping problem, constipation. These are the things that you have to discuss with the parents. Okay, anything else?
I think no.
Okay, that's all. If you've got any questions, you can ask me. Send me your presentation. I'll get back to you the marks. Hopefully by weekend ke, tengok lah. I'm a bit busy lah this week. I think that's all lah. Okay, we can postpone dengan tasbih kafar. Nasrullah.
Thank you, doctor.
Thank you, Doctor.
Warahmatullahi wabarakatuh.
Thank you, Doctor.
No worry.